शुक्रवार की शाम डॉक्टर्स के नाम कार्यक्रम में आप सभी का स्वागत है। अब तक इस कार्यक्रम के 69 एपिसोड का लाइव प्रसारण किया जा चुका है, जिसमें आप सभी की भागीदारी बेहद सराहनीय रही। यह कार्यक्रम अब तक 2 लाख से अधिक बार डॉक्टर एवं स्वास्थ्य सेवा प्रदाताओं द्वारा देखा गया है। हम उम्मीद करते हैं कि आप इसी तरह इस कार्यक्रम से आगे भी जुड़े रहेंगे और इसका लाभ उठाएंगे। यह कार्यक्रम प्रमुख सचिव चिकित्सा स्वास्थ्य एवं परिवार कल्याण की प्रेरणा से एवं चिकित्सा स्वास्थ्य एवं परिवार कल्याण विभाग के सहयोग से राज्य स्वास्थ्य एवं परिवार कल्याण संस्थान उत्तर प्रदेश द्वारा संचालित किया जा रहा है। अब तक इस कार्यक्रम में प्रदेश के कई जाने माने विशेषज्ञों ने स्वास्थ्य के कई महत्वपूर्ण पहलुओं पर विस्तृत चर्चा की है। इस कार्यक्रम में अभी तक कार्डियोलॉजी, डायबिटीज, डायरिया प्रबंधन, आयुष्मान भारत प्रधानमंत्री जन आरोग्य योजना, आयुष्मान भारत डिजिटल मिशन, मेडिको लीगल, मातृ एवं शिशु पोषण, हेपेटाइटिस, पेरिफेरल वैस्कुलर रोग, सामान्य नेत्र विकार, क्षय रोग, कुष्ठ रोग, क्लिनिकल योग एवं जीवन शैली के विकार, वेक्टर जनित रोगों का प्रबंधन इत्यादि विषयों पर विस्तृत जानकारी प्रसारित की जा चुकी है। इसी क्रम में आज के 70वें एपिसोड में हम बात करेंगे वयस्क टीकाकरण पे, और इस विषय पर बात करने के लिए हम लोगों के मध्य डॉक्टर अंबुज यादव साहब हैं, जो एम.डी. मेडिसिन और पीडीसीसी हैं क्रिटिकल केयर में। आप एसोसिएट प्रोफेसर हैं मेडिसिन विभाग में, किंग जॉर्ज मेडिकल यूनिवर्सिटी लखनऊ में। हम लोगों के बीच में मौजूद हैं। ये आपसे वयस्क टीकाकरण पर विस्तृत चर्चा करेंगे और आपकी जो भी जिज्ञासाएं होंगी, जो भी सवाल होंगे, उसका जवाब देंगे। तो डॉक्टर साहब, आपका स्वागत है। और इस कार्यक्रम को शुरू करने से पहले राज्य स्वास्थ्य संस्थान की तरफ से हम एक छोटा सा भेंट देना चाहेंगे।
थैंक यू सर।
वेलकम सर। हम डॉक्टर साहब सब रिक्वेस्ट करेंगे कि डॉक्टर साहब आज इस वयस्क टीकाकरण के बारे में चर्चा स्टार्ट करें। सर।
नमस्कार। सबसे पहले तो मैं धन्यवाद देना चाहूँगा प्रिंसिपल सेक्रेटरी सर, मेडिकल हेल्थ एंड फैमिली वेलफेयर उत्तर प्रदेश श्री पारसनाथ सारथी शेन शर्मा सर, डायरेक्टर अर्चना वर्मा मैम एंड डिप्टी डायरेक्टर डॉक्टर मोहित सिंह सर का, जिन्होंने मुझे इस कार्यक्रम में अपना टॉक देने के लिए इनवाइट किया। थैंक यू। अच्छा, सो टुडे वी विल टॉकिंग अबाउट एडल्ट वैक्सीनेशन। आज का जो हमारा विषय है वो एडल्ट इम्यूनाइजेशन या वयस्क टीकाकरण है, जो कि एक बहुत इंपॉर्टेंट टॉपिक है। जैसा कि हमें पता है कि हमारे पीडियाट्रिक पॉपुलेशन में ये इम्यूनाइजेशन बहुत ही अच्छी तरीके से व्यवस्थित रूप से पूरे प्रदेश में संचालित है, परंतु एडल्ट में, वयस्क लोगों में ये इम्यूनाइजेशन अभी उतना अच्छी तरीके से वैक्सीनेशन नहीं हो रहा है। तो आज का कार्यक्रम इसमें जागरूक करने के लिए तथा इसके विभिन्न जो वैक्सीन प्रिवेंटेबल डिजीज हैं उनके बारे में हम विस्तृत vaccines to these adult pupils. And especially important is that what I mean to say is this vaccination, adult vaccinations, these are very effective in preventing various infectious diseases like influenza, pneumonias, shingles, herpes zoster, which is also called as herpes zoster, hepatitis and tetanus. This is not limited to these diseases. There are many more diseases as well that we will be discussing about. Now we also know that when a significant portion of population is immunized, it creates a herd immunity which helps in indirect protection to those who are unable to receive the vaccine for various medical condition, be it immunosuppressions, the patient who are in immunosuppressive drugs, or the patient who are having retropositive, who are having immunosuppression, transplant patient especially. So the adult immunization plays a very crucial role in maintaining the health workforce and preventing the disease outbreak in the community settings too. So these vaccines not only protect the individuals but also help reducing the transmission of this vaccine preventable infectious diseases too. So that is the importance of adult vaccination. So if we are giving the vaccines to the adult population, probably we might be preventing the various diseases, especially the high risk group which are very prone to getting infections of this. And these high risk group may be in the form of immunocompromised systems like the patient who are suffering from HIV, immunodeficiency syndrome, neoplastic disorders, and the important ones are the post-transplant patient who are very prone to getting infections because of the immunosuppressant drugs which they are receiving. In the recent year, we have seen the development in the medical field because of which there is the life expectancy has drastically improved. So as the age advances, these patients are vulnerable to various vaccine preventable diseases. So if we vaccinate such individuals, probably we might be stopping these patients to getting preventing the mortality and morbidity in these elderly group of patients. Now, one of the important things is that some of this high risk group, these are specifically occupational. There is something which is called as occupational exposure, specifically for our healthcare professionals like doctors, like nurses, other staffs, paramedical staffs, which are working tirelessly in their hospital setups. Now, these are the peoples who are continuously exposed to the various infections. So, by vaccinating these healthcare professionals, probably we might be interfering, we might be stopping these vaccine preventable diseases to occur in such type of population. Also, it is important that if somebody wants to travel to an area where the particular disease is endemic, so we should before the visit to that endemic area, if we vaccinate that with that particular vaccine preventable disease, probably it may interfere. This traveler might not get that infection which he might get if he is not vaccinated. So that these are the basically high risk group which are specifically be vaccinated with these vaccine preventable diseases. Now we must understand that this adult vaccination is a need of our actually, right? So this adult vaccination, it boosts the childhood vaccines, and there are many individuals who have missed vaccination during the childhood because of various reasons. So these are the individuals who need vaccination in the adults. Also, there is loss of immunity over the time, and the immunity for the newer comorbidities which develops as the age advances, for example immunosuppressions, diabetes and all. So these are the patients who are very prone to getting this vaccine preventable diseases, so which can be prevented by adult vaccination. Also, we must protect our mothers and newborns specifically with the tetanus by simply giving a jab of this tetanus, diphtheria and pertussis vaccine. And we have seen the COVID-19 pandemic, which was a threat for our Indian population, not only in India but all over the world, which we have prevented by this vaccine, COVID vaccines. So this is the importance that this adult vaccination is to be done in all adult patients also. So what are these vaccines actually? So these vaccines are biological substances that stimulates the immune system to develop immunity against the specific diseases. So these are the biological substances actually which stimulates the immune system. So there are various types of vaccine. If we look about the various types of the vaccines, we have live attenuated vaccine, inactivated or dead vaccines, then acellular vaccines which includes toxoid vaccines like diphtheria and tetanus toxoid vaccines, conjugate, split viral vaccine, protein subunit vaccines, we have recombinant vaccines like COVID vaccines, we have seen mRNA and DNA vaccines, and we have also something which is called as viral vector vaccines. So these are the various examples of inactivated, live attenuated mRNA vaccination, viral vector vaccines we have seen of this COVID-19 vaccines. We have subunit, recombinant, polysaccharide and conjugate vaccines, and we have toxoid vaccines. So these are the various examples of various vaccines which are present in which are there, which we need to give the patient to adult population. So one of the important concerns is that, are these vaccines safe? So what I say is that in the pediatric population, a father very happily goes to vaccinate his children, but he himself doesn't get vaccination, while he is the father of that particular child. He is going to take care of that particular child. So that is why are we so hesitant, why we are not so going positively with adult vaccination. So there is very concern about the safety of vaccines. Now let me tell you, these vaccines does not come in a day or two. These vaccines go through years of testing before the regulatory authorities license them for use. These authorities not only give the regulatory authority, but also they continuously track the safety of all licensed vaccines. There is also the side effects are there, but usually they are mild and usually they go away within a day or two. They include fever, pain, redness and swelling at the site. Severe side effects like anaphylactic reactions are very rare. That is why it has been said that vaccine is one of the safest way to protect the healthcare system. So if you want to invest in your health, please do get vaccinated in the adult population. Do get vaccines in the adult population too. So having said that, let us move over individual vaccines. So first vaccine which I would like to discuss is influenza. Now this influenza is a virus which we know it has 4 types: influenza A, B, C and D. Now A and B are the viruses which cause disease in the human populations. It caused by influenza can infect the animals and the human as well. A and B usually cause the disease in this human population. Now this influenza is not limited to the respiratory tract. Actually this is the infection of respiratory tract, but it has a multisystemic involvement. It can involve the respiratory tract, it can involve the cardiac system, it can aggravate the various lung diseases. Specifically there is high risk patient who are suffering from various lung diseases like chronic obstructive pulmonary disease, asthmatic patient, interstitial lung disease patients, the patient who are having cardiac illness. They can aggravate this chronic heart failure patients. So this virus is not only infecting the upper respiratory tract infection, it involves a multisystemic diseases. It can involve the multisystem too. Now this influenza, there are having said that there are 2 types and various serotypes are there. Now this influenza have tendency to there is something which is called as antigenic drift and antigenic shift. Now these are 2 are responsible for various endemic and seasonal variations in the influenza virus which are circulating in the community. Now this antigenic shift, it is basically it causes the seasonal change. There is mild change in the vaccine structure, and because of which it can lead to local endemics. But if there is an antigenic drift, actually it is responsible for the pandemics and all, and we have seen that various pandemics have occurred because of this influenza virus. Not only this one virus is such a virus that it has caused a lot of pandemics and caused lot of mortality and morbidity than any other disease as such. So why do we not vaccinate our adult population with influenza, specifically the high risk patient, the patient who are suffering from chronic organ disease, end organ disease, like it could be chronic liver disease, chronic heart disease or any other chronic disease, specifically the patient who are having immunosuppression states too. So we have 2 vaccines as such. We have inactivated influenza vaccine which is given by intramuscular route, and we have live attenuated influenza vaccine which is given by intranasal route. Always to remember, the live attenuated vaccines should be given. There are some little bit contraindications when we are using live attenuated vaccines of any type. Then we must be knowing that what are the various contraindications that we'll be discussing in the coming slides. Now the dose is 0.1 ml. It is given to be annually, and as we said that every year there is change in the seroprevalence. So this we have to do a seroprevalence of that of influenza, which strain is prevalent, and depending on that, usually we have tetravalent or quadrivalent vaccine which is supposed to be given annually, means every year we have to get ourselves vaccinated. Now there are concerns that when should we vaccinate ourselves. So as such, this influenza vaccine is circulating. The cases have been found throughout the year, but specifically we see if we are living in the southeastern South India, then before the monsoon, and in the northern states, we have to give the vaccine in the before the winter season. So April, May, and September, October are the best time depending on the area which we are living. In the adults, including the pregnant women. Now specifically pregnant women, why I am saying, because if the pregnant women get influenza, now these patients can deteriorate drastically. So it is very important, even in a pregnant woman, that she also should receive a single dose of this influenza yearly. So all the individuals, all the adults must receive inactivated influenza vaccine. But if it is a live attenuated vaccine, it is only for the adult less than 49 years of the age. Now we must know that there are various contraindications of this live vaccines. For inactivated vaccine can be used safely, but if they are live vaccine, these are contraindicated specifically in the age group more than 50 years, pregnant women, if there is history of allergic reaction to any of the excipients of this vaccines or egg, immunocompromised, if the patient has received antiviral therapy in less than 24 hours, and patient with asthma, Guillain-Barré syndrome, and various chronic conditions, so this live attenuated vaccine probably should not be given, and we should be giving this not live attenuated, but we must give inactivated vaccines. So sometimes what we see that the patient needs this influenza vaccine, the patient needs this MMR vaccine, the patient needs any other vaccine. So how should these be given? So if the two or more of the live vaccines are given, probably they should be given on the same day, or if not given on the same day, they must be spaced by at least 28 days between the two live vaccines, and if it is a yellow fever vaccine, it must be 30 days. Other inactivated vaccine and subunit vaccines can be added as and when indicated. So if you see the Indian consensus, up to the age of 18 to 49 years, almost every individual must be vaccinated. Also beyond that, we must be giving the inactivated vaccine, and if it is a live attenuated vaccine, it must not be given above 50 years, pregnancy, immunocompromised state, retropositive, and the patient who have ASPNA and complement deficiencies, where we should not be using the live attenuated vaccine. But yes, all these patients must receive inactivated influenza vaccines too. Now that other type of respiratory infections which can cause by this streptococcal pneumonia infections is that there are pneumococcal diseases. Now this streptococcus pneumonia, this can cause various disease which is called as streptococcal pneumonia syndrome, that can primarily involve the lung, but that is not restricted to lung. They can cause bacteremia, they can cause acute otitis media. So if this pneumonia occurs, they have a devastating effect because of pneumonia. Many of the patients, specifically again the high risk patient, the patient who have end organ damage in the form of chronic obstructive pulmonary disease, asthmatic patient, interstitial lung disease patient, heart disease, CSF leak patient. So these are the patients who have severe disease and must be vaccinated by pneumococcal diseases. So we have something, there are two types of pneumococcal vaccines. One is, this is known as PPSV or pneumococcal polysaccharide vaccine. It protects against 23 serotypes of strep pneumonia serotype, and we have conjugated vaccines which can be PCV 13, 15 and 20 depending on how many type of serotypes that particular vaccine has. As of now, we have PPSV 23 and PCV 30 which must be given in the patients in Indian population. So if it is a PPSV, it is given intramuscularly or subcutaneously, and 13 is to be given intramuscularly. Now the dose is, one dose of PCV 13 should be followed by PPSV 1 year later. So that is important. Initially we should be giving this PCV 13 followed by PPSV 23. Also, it has been seen, if I want to co-administer the other vaccines, so if there are the rule applies the same. If they are live vaccine, they can be given at the same time. Or must be spaced at least 28 days. On the other vaccines could be given as and when required. So the key consideration while giving a pneumococcal vaccine is that it is recommended for all, especially for the increased risk irrespective of the age, one dose of PCV followed by one dose of PPSV 23 1 year later. Now if the patient belongs to the very high risk, then PCV 13 can be followed by PPSV 23 8 weeks later too, because 1 year is a pretty long time. So simply if we space PCV 30 and PPSV 23 for the 8 weeks, so these are the high risk, specifically the high risk patient, they can get vaccinated after PPSV 23 8 weeks after the PCV 23. PCV 15 and 20 are not available in India as of now, but they haven't recommended above if the patient is above 50 years, one dose of PCV 20 will suffice. There is no additional dose needed. But if we are vaccinating with PCV 50, it must be followed by PPSV 23 1 year later. And again, if it is a high risk, then this duration can be shortened to 8 weeks. 8 weeks. PPSV 23 can be given after this PCV 15. One of the important disease which we came across in the recent past was COVID-19, and everybody was scared, and we were able to contain this infection by simply vaccinating. This was one of the very important intervention which by which we are able to contain this infection. So there are multiple vaccines which have been approved in India. So as of now we have 2-3 important vaccines which we have. One is Covishield and one is Covaxin. Now this Covishield is a viral vector vaccine, while Covaxin is developed by Bharat Biotech, is an intriguing Indian vaccine, and it is an inactivated vaccine. Now these vaccines must be given, 2 doses of each vaccine must be given. If we are using Covishield, if it is given for more than 18 years, 2 doses 4 to 6 weeks apart intramuscular must be given. And if I am using Covaxin, again it is used for 18 years, 2 doses 0 to and 28 days it must be given. Now there are various concerns with Covishield vaccine that they cause this thrombocytopenic syndromes. As of now, various regulatory authorities have cleared that there are no as such increased risk of thrombotic and this thrombocytopenic syndrome, even we are using this Covishield vaccine as such. Also, the risk is much less than the benefit. So all the patients, either they must receive Covishield or Covaxin vaccines. Now if we see the Covishield vaccine, these are the viral vector vaccine. The immunogenicity is very good as compared to Covaxin. So if we have to vaccinate, so probably there is no point in not taking vaccination. We must be vaccinating either with Covishield or Covaxin. And there is another vaccine which has been available, which we must be talking about. These are mRNA vaccines. Now these vaccines are very good again, but availability is an issue, the storage is an issue. They must be stored at the temperature of minus 25 to 15 degrees centigrade. But the best point is these are one of the very effective vaccines, and which was developed by Moderna vaccines. These are the other vaccines of COVID-19 which have been approved in Indian setup. Now, some of the things we must be talking about, that at the time of pandemic, all the local epidemic situation, routine administration is strongly recommended for all, even in the pregnancies, and these are 2 doses at least 4 weeks apart must be given. Additional booster dose usually is not recommended, but it is recommended for all older adults and adults with significant comorbidities or obesity, which should be a high priority use of this group, and at least if at all given the 3rd dose, it must be spaced at least 12 months before the previous dose. So if you see the Indian consensus recommendation, it is that even if the patient is 18 years or more or 50 years or more, everyone should be given this COVID-19 vaccine, be it pregnant, be it immunocompromised, be it retropositive, asplenia, or chronic health diseases like CKD, heart disease, chronic liver diseases, diabetes, healthcare workers specifically, and travelers and mass gathering. So all must be receiving this COVID-19 vaccination. Forget about what are the side effects and all. The next vaccine which I will be talking about is the Haemophilus influenza. Now this is a vaccine. We have 2 types of basically lyophilized killed and conjugated vaccine. Now it is route of administration is intramuscular. It is available as pentavalent, bivalent or hexavalent injections. Dose is 1.5 ml one dose, and specifically important, these are some of the patients who are immunocompromised, specifically hematopoietic stem cell transplant. Now these patients are specifically prone to getting infection by this Haemophilus influenza, this bacteria. So what must be doing? We must be vaccinating the patient who have this transplant recipient, and specifically the hematopoietic stem cell transplant. They must receive 3 doses at least 4 weeks apart to all the patient of HSCST recipient patient. Important thing is that we must have be considered that this is not a part. This is a part of primary immunization, and also the patient, high risk patient, specifically the immunocompromised, CSF leak, trauma, diabetes, pregnancy, alcohol, cancer, the patient who are receiving chemotherapy and radiation, 1 dose will suffice. Specifically the patient who are having splenectomy, they need to be vaccinated at least 14 days before splenectomy. patient who are having functional or anatomical aspenia, again if unvaccinated they must receive one vaccine. And the patient who have a stem cell recipient patient, hematopoietic stem cell recipient transplant patient, these must receive 3 doses at least 4 weeks intervals and 6 to 12 months after transplant, regardless of this vaccine history of vaccination in the past. So these are the very important group of the patient. The high risk patient specifically must be given this Haemophilus influenza type B vaccination. Again, talking about the Indian consensus, that this also shows that these are recommended above 50 years, immunocompromised, patient who have CKD, heart disease, CLD and diabetes mellitus. They must be given this influenza 1 dose of vaccine to everyone. Now again we see that chickenpox is one disease which usually causes which usually occurs in the childhood, but it can occur in the adult. Usually it is not causing very problems, but it can cause severe problems in adult in the form of encephalitis, in the form of pneumonias too. So why not we prevent this chickenpox by simply vaccination? So we have a live attenuated vaccine of chickenpox. It must be given intramuscularly. 2 doses recommended, 0.5 ml, and must be spaced at least 4 to 8 weeks apart. Now it is also said that it is a routine recommendation in adults without evidence of immunity. Also recommended in the adults who are at potential risk of individuals, for example the patient who are students who are residing in hostel, healthcare practitioner and household contacts. So these are the patients who have, because the chickenpox have, the attack rate is very high, because once the rate of infectivity is very high. So if the patient is infected, the students who are living, for example the students who are living in the hostel, the other students can also get infected by this chickenpox. There is something which is also post-exposure vaccination. It is recommended within few days to few weeks of exposure. If there is history of incomplete vaccination, 1 dose, and if the patients are not, if the individual is not vaccination, so they must receive 2 doses of this. So Indian consensus, talking about consensus recommendation, it is recommended in the aspenia complement deficiency patient, CKD, heart disease, CLD, diabetes and healthcare. Specifically, we ourselves must be vaccinating with this chickenpox vaccine. Now this chickenpox is not only limited to this chickenpox. These virus, this herpes zoster virus, they get and remain dormant in the dorsal root ganglia, which can reactivate in the elderly specifically. Now where it can cause severe pain. Not only this, though rare, but it can also cause this encephalitis and pneumonia like diseases. So that can be problematic, specifically in the elderly people. So we have shingles or herpes zoster vaccine too. These are recombinant zoster vaccines and must be given subcutaneous in the deltoid or the anterolateral area of the thigh. It is recommended 2 doses, 0.5 ml, 2 to 6 months apart must be given. So routine recommendation, all people above 50 years of age, 2 years, 2 to 6 months apart. Minimum gap between the two must be the 4 gap. So it is recommended in the patients, in the individuals who are more than 50 years, means this is a vaccine of elderly too. Now this is also recommended in the patients who are immunocompromised, right, HIV. Now this chickenpox and this shingles, herpes zoster, usually it causes mild infection in the immunocompetent, but if the patient is immunocompromised, there could be complication of this virus. So it is important that the patient who are immunocompromised, be it HIV, be it immunocompromised state, heart disease, lung disease, these all must receive this shingles vaccine, and specifically the elderly population who are more than 50, they must receive 2 doses of shingles vaccines too. Again, talking about next, we will talk about this diphtheria, pertussis and tetanus vaccine. We have seen a number of cases of diphtheria, of adult diphtheria cases too. Tetanus is not unknown to anybody. We have seen that despite having a robust immunization program, specifically in the pregnant ladies, we do get multiple tetanus patients every year. And this can be a leading cause of mortality and morbidity. These are the tetanus patients. They have muscular spasm, and they can these problems could be in the form of upper respiratory. There could be strong spasm, which may lead to protection of the airway, may need intubation, and these patients may need ventilatory support for a pretty long time. Usually, it can take for 4 to 6 weeks. So when they are patient ventilated, when they are in the ICUs, obviously they are at the risk of hospital acquired infection, at the risk of ventilator associated pneumonias. So why don't we prevent these patients before going to the ICUs? Why don't we vaccinate these patients with tetanus? So we see we have Tdap, diphtheria, tetanus toxoid, and acellular pertussis antigen, and we have Td in the form of diphtheria reduced dose and tetanus toxoid. The route of administration is intramuscular, must be given 0.5 ml one dose every 10 yearly. So every 10 year, each individual must be receiving this Tdap vaccine, be it pregnancy, be it immunocompromised, be it anything else. So this is one of the important diseases, which is vaccine preventable again. So we must be knowing that if the patient is unvaccinated, first dose of Tdap should be given, then the one dose should be the next dose 4 weeks later, and the third dose 6 to 12 months later. Now, if the first dose is given, it is preferred that we should vaccinate not with TD but with Tdap. So, and after that, we must be giving either Tdap or TD vaccine every 10 years. It is also recommended during pregnancy. Then every pregnancy, every time the patient get pregnant, then we are supposed to give Tdap vaccine, preferably between the gestation age of 27 to 36 weeks. Also talking about wound management, if it is a clean or minor wounds, we must administer Tdap or TD if more than 10 years since the last dose, or for all the other wounds we must be administering the Tdap or TD if it is more than 5 years. So 5 years for the other wounds, minor wounds it is 10 years. So Tdap is preferred for the persons who are not having previously received Tdap or whose Tdap history is unknown. So if I am not knowing the patient what dose he has received, so preferably we should be vaccinating with Tdap. And tetanus toxoid containing vaccine is indicated for the pregnant. Use Tdap, not TD. Now this hepatitis A virus. Now usually it is said that many of us are exposed to hepatitis A. The adult usually doesn't need this hepatitis A virus. Now it has been shown that yes, many of us have the immunity against hepatitis A in the childhood, but if not immune, this hepatitis A virus even can cause fulminant hepatitis, which is life-threatening situation. So again, why not be giving vaccination of hepatitis A, specifically in the high-risk population where we see that the disease is very severe. So we have inactivated hepatitis A vaccine, must be given intramuscularly. 2 doses usually suffice, 6 months apart, and it is contraindicated in pregnancy. Here what we have two different types of scenarios. The patient, some of the high risk patient, we can give 2 doses if we are giving only hepatitis A at 6 and 12 months apart, or this dose can be combined with hepatitis A and hepatitis B, where 3 dose series can be given, 0, 1 and 6. Now some of the patient, the individuals who are traveling in the countries with higher and intermediate endemic hepatitis A, there we can shorten the schedule. We can give an accelerated schedule of 3 doses at 0, 7 and 21 to 30 days. We can give 3 doses here, but these patients must receive a booster dose at 12 months. So accelerated schedule must be given 0, 7 and 21 days. Routinely it is given 2 doses if alone hepatitis A 6 months apart, and if it is given with hepatitis B, it is 0, 1 and 6 months. But we should understand that who are the individuals who are at high risk of hepatitis A. The patients who are suffering from chronic liver disease, be it hepatitis B, C, cirrhosis of any cause, fatty liver disease, alcoholic liver disease, autoimmune hepatitis, any of these are very high risk of hepatitis A. Also, the patients who are having higher levels of transaminase like SGOT and SGPT are raised more than twice than upper normal limit. So these patients also must receive hepatitis A vaccine. The patients who are undergoing liver transplant, retropositive patient, men who are having sex with men, IDUs, injection drug abusers, the patient, also the persons, researchers who are working in the research laboratory where there is hepatitis A virus research is going on. So these are the individuals who are at risk and must be vaccinated with hepatitis A. So if we see the consensus guidelines, again if the patient is having hepatitis A, yes, we have to HIV, we have to give the hepatitis A vaccine, and specifically the patients who are suffering from chronic liver diseases, like which could be any form, if they are having this SGOT and transaminitis more than 2 times the upper normal limit, liver transplant patient, these are the patients who must receive hepatitis A vaccination. Same as hepatitis A, we see that the risk of the hepatitis A and hepatitis B is same. So hepatitis B, this can cause chronic liver disease as such, and this chronic liver disease can progressed hepatocellular carcinoma. So this is a vaccine preventable disease again. So we must vaccinate all the individuals with hepatitis B, specifically the high risk patient. So what are the vaccines? We have recombinant DNA vaccines and plasma derived inactivated subunit vaccines. It is administered deep intramuscular in the deltoid. Buttocks must be avoided, and dose is 106 months, as we have seen with the hepatitis A virus. We have some contraindications. If there is history of allergic reaction to the vaccine or the history of reaction with the Baker's yeast, then probably this vaccine must not be given. Here also again we have some considerations. So if we are giving hepatitis B alone, 3 doses will suffice, 0, 1 and 6 months. If I am giving the hepatitis B and hepatitis A vaccine at the same time, specifically in the travelers, then we can give the accelerated schedule of 3 doses, 0, 7 and 21 to 31 days, followed by a booster dose of 12 months. Now again, who are the individuals at high risk? It is same as the hepatitis A virus. The patient who are having chronic liver disease, the patient who are going underlying liver transplant, HIV infections, men 6 months, men having sex with men, and injection drug abuser patients. Again, if you see the Indian consensus recommend, it is for the age 18 to 49, be it pregnancy, immunocompromised, retropositive, asplenia, other end organ damage like kidney, liver and heart, diabetes, healthcare professionals and travelers, these all patients must be receiving this hepatitis B vaccine 3 doses. And we have to keep in the mind that some high risk individuals, specifically the patient who are having chronic kidney disease, who are having continued on maintenance hemodialysis, the patients who are immunocompromised, and some of our healthcare practitioners even can revaccinate every 5 yearly, because these patients immunocompromised, CKD and maintenance hemodialysis, these are at very high risk. So revaccination can be considered every 5 years if there is these high risk individuals. Now, one of the viruses which is a cause of this very important malignancies, specifically in the females, which is the cause of cervical cancers, and which is none other than human papilloma virus. Now this virus causes cervical cancer, which is the leading cause of cancer in the females. Not only this, it can cause anal cancers in the males too. It can cause various genital warts. So genital warts, anal carcinoma and cervical carcinoma, the cause is human papilloma virus. So again, there are various subtypes of, there is various serotypes of human papilloma virus, which like 6, 11, 16 and 18, and there are various other types of other serotypes too. So we have recombinant protein capsule liquid vaccine, which is available in bivalent, quadrivalent and nanovalent. So usually we are giving the quadrivalent vaccine to as the routine this immunization schedule, adult immunization schedule. So which contains HPV serotypes 6, 11, 16 and 18, and route of administration intramuscular, and the dose is 1 ml, 2 to 3 doses, 0, 1 and 6 months, depending on the age of the patient. Now this vaccine is given before the first sexual intercourse is encountered. Now HPV vaccine, depending on the age, 2 or 3 doses can be given. If the age is 15 years or older, at the time of initial vaccination, 3 dose series can be is given, usually at 0, 1 and 6 months. If the age is 9 to 14 years, so this HPV vaccine must be given as early as 9 years of the age to prevent the further risk, because it is not recommended above 45 years. So if the age is 9 to 14 years at the time of initial vaccination, and 1 or 2 doses have given, if it is the spacing between the 2 vaccines is less than 5 months, then 1 extra dose is needed. If it is more than 5 months, then no extra dose is needed, and 2 doses will suffice in the age between 4 to 19 years. The adult age from 27 to 45. Now this was up to the age of 26. So usually recommended this HPV vaccine ideally must be given before first sexual this encounter, or before the 26 years of the age. After 26 years, 27 to 45, it is based on shared clinical decision making whether to vaccinate or whether to not to vaccinate. Immunocompromised state, specifically HIV. Now this HIV, if it is occurring with HPV vaccine, the incidence of this carcinoma, this cervical carcinoma, increases. So that is why these patients who are suffering from HIV infection, 3 dose series, even who have started immunization at the age of 9 or 14, must be given. So immunocompromised must be receiving HPV vaccination too. All recommendation, as I told, all the recommendations specifically in the HPV, human papilloma virus, is for below the 45 years of the age, and ideally 26 years of the age. There is no recommendation to use in pregnancy, but about this HPV vaccine during the pregnancy, consider delaying HPV vaccine until the pregnancy. Talking about the recommendation of Indian consensus, again, if the age is 18 to 45, the HPV human papilloma vaccines must be started as early as first dose must be given as early as at the age of 9 years, and it must not be given after 46 years of age. Now, one of the devastating diseases which we see specifically in the Uttar Pradesh too, that is in the children, that is Japanese encephalitis. Now, this can occur in the adults too. The persons who are traveling to the endemic zones, they do need get. Usually, it is not recommended as such, but the travelers, the high risk patient who are traveling to the endemic areas of where the Japanese encephalitis is prevalent, so they need to get vaccinated before going there. So we have live attenuated vaccine and inactivated vaccines. 5 ml inactivated vaccine, 2 doses at least 4 weeks apart must be given, and it is contraindicated as a live vaccine should not be given during the epidemic of this Japanese encephalitis. So what consideration should be given, what we should consider before giving the Japanese encephalitis vaccine? So the patient who are travelers who plan to travel in the endemic regions for one or more month. So depending on the exposure, so if the exposure is long, more than 1 month, probably I will be giving this Japanese encephalitis virus. And if the exposure is less than 1 month, but they are planning to stay longer period outdoors, rural areas, agricultural areas, engage in the outdoor activities, so probably I will like to vaccinate this patient with Japanese encephalitis. This vaccination is not recommended for short-term travelers who plan relate exclusively to the urban areas, and the patients with chronic illness or immunodeficiency who live in or move to these endemic areas, they also must get Japanese encephalitis virus. So if they are living, if the exposure is high, if the duration is more, if there is immunodeficiency, if they are moving to the endemic areas, so they all must be given this Japanese encephalitis vaccine. Pregnant women traveling or staying to endemic areas, always the risk benefit ratio must be based, and if the benefit is more, probably vaccinate, otherwise leave that. Recommendations specifically in the travelers who are having the exposure of Japanese encephalitis, who are going to areas where the endemic areas, so these are the persons who must receive this Japanese encephalitis vaccine. Talking about measles, mumps and rubella, which is a important vaccine, MMR vaccine, which is given in childhood, but these are the live attenuated combined vaccines, must be administered subcutaneously. 2 doses 4 weeks apart must be given, but precautions must be given specifically to the patient who have mild or severe acute illnesses with or without fever. That's one. And if the person has received blood plasma immunoglobulin in the recent past, they probably will wait for 3 months before vaccinating these patients. The persons who have history of thrombocytopenia or thrombocytopenic purpura, these are the high risk patient, and these vaccination must be given with very precaution. Every precaution must be taken before vaccinating these patients. This MMR vaccine is not advised during pregnancy because of potential fetal harms, but in case any of the pregnant lady has been given this MMR vaccine, there is no point in terminating the pregnancy, because still there is no proof that MMR or MMRV vaccine which is available in the market are teratogenic, have teratogenic risk. So women may receive MMR vaccine in the outbreaks, specifically if there are outbreaks of measles and rubella outbreaks, so possibly even the pregnant women we will be vaccinating, because the advantage of vaccination outweighs the dangers. We must be considering this MMR is a part of routine vaccination. If unvaccinated, 2 doses at least 4 weeks apart must be given. If a woman of childbearing age is found to be rubella susceptible and is not pregnant, give 1 dose of MMR. If she is pregnant, the dose should be given postmortem. So probably to avoid, but if given during pregnancy, there is no point in terminating, because till now we don't have any evidence that this MMR vaccine has a teratogenic effect. But if the outbreak occurs, then even the pregnant females must be vaccinated, because again, as we discussed, the advantage is more than the risk of these diseases. Talking about the recommendation again, specifically the healthcare workers, these must be vaccinated, and the patient who are aspenic and complement deficiency, Indian consensus have documented that they must be get a dose of MMR. So we, the doctors, the healthcare professionals, nurses, paramedical staff should get MMR vaccine, if not. Now, meningococcal, again this disease is a very devastating. If it occurs, it can cause meningitis and can cause bacteremia, it can cause septicemia, and ultimately the patient can end up in multi-organ failure. So Neisseria meningitis is one of the important causes of this meningitis. Not only meningitis, but it can also cause systemic disease. It can cause bacteremia, which is a very deadly disease, and if not treated, the patient succumbs or can land in various mortality and morbidity. So for this, we have purified bacterial capsule of polysaccharide vaccine, and we have a conjugate vaccine too. So dose is 0.5 ml. One dose needs to be given, specifically the patient who has high risk. So who are the patient who must be given? So the patient, specifically the patient who have functional or anatomical aspenia, including sickle cell disease, HIV patient, persistent complement component deficiency, and the patient who are on complement inhibitors like eculizumab, 2 doses at least 4 weeks apart, and these are the patient who must be revaccinated every 5 years if the risk remains. So ideally it is 1 dose will suffice, but in these patients, if the risk percent, they can be revaccinated every 5 years. The individuals who are traveling to the countries who are hyperendemic or endemic meningococcal disease, also if there is mass gathering, the microbiologists who are routinely exposed to Neisseria meningitis, they must also receive 1 dose, and if the risk remains, they again should be revaccinated every 5 yearly. So travelers, the patient who have functional aspenia, persistent complement deficiencies, retropositive patients on complement inhibitor, these are the patients who must be vaccinated with this meningococcal vaccine. Other patients are the patient who are college students who live in the residential or military residential housing, or these are military camps. These are also people who must be given meningococcal vaccine. So it is recommended only up to the age of 55. After that, it is usually not recommended if there is no additional risk factors. So these are recommended. If we talk about Indian consensus recommendation, it is recommended in the HIV patient, aspenia, complement deficiencies, travelers, and specifically the travelers if they are traveling to endemic regions, and if there is mass gathering, then again this meningococcal vaccine must be given, 1 dose. Poliomyelitis, we have as we know that there are 2 types of polio vaccines, live OPV, that is oral polio vaccine, which is live attenuated, and we have inactivated this inactivated polio vaccine, that is to be given IM. Dose is 2 drops oral polio vaccine, 3 doses 0, 1 and 6 to 12 months. Live vaccines are contraindicated in pregnancies. Now we must be considering that if the patient is previously vaccinated, 1 lifetime booster of IPV is to be given. Travelers to the countries where the polio is endemic or epidemic or endemic, these are the peoples who must be given this vaccine. Laboratory healthcare workers who handle the specimens that might contain polio virus must be vaccinated. Healthcare professionals or the caregivers who have the close contact with the person who could be infected with polio vaccine, these are the persons who must be given this polio vaccine. If they are unvaccinated or incomplete vaccinated adults, 3 doses, again 3 doses if they are unvaccinated, first dose at any time followed by second dose at least 1 month later, and the third dose to be given 6 to 12 months after the second dose. So if unvaccinated, again 3 doses. Other thing, we have the single dose of IPV, the booster, it is actually a booster dose of IPV, single dose must be given. Travelers, the healthcare workers, and the persons who are caregivers of the close contact of the patient who are taking care of the polio virus patients. So it is basically for the travelers. Indian consensus recommends all the travelers who are going to endemic regions must receive this IPV as a booster dose of IPV, single dose. Talking about rabies, now this is a disease, if occurs, there is 100% mortality is going to occur. So not many cases, not only in India but in the world, have survived because of virus. So that is the importance of vaccinating. So if at all the patient has been bitten by the rabid animal, it can be given pre-exposure or it can be given post-exposure. So this is a very important vaccine, very effective vaccine, and must be given vaccine if indicated. So we have something which is called as concentrated purified cell culture and inverted egg based vaccine, which are available in India as human diploid cell vaccine or purified chick, duck and vero cell rabies vaccine. Routine administration is IM, but it can be given intradermal too. Dose is 0.5 ml if we are using purified vero cell rabies, and 1 ml if other vaccines are used. It is contraindicated if there is history of allergic reactions, egg allergy, pregnancy, lactation and immunosuppressive state. Now what are the key considerations? Now there are two things. If there is high risk of exposure, for example, if any animal handler, the individuals who are handling the animals, the researchers who are exploring the caves, or the studying the rabies virus, so these are the pupils who must be receiving the pre-exposure prophylaxis. The doctors who are treating the rabies patient, so these must receive pre-exposure vaccine, and the pre-exposure vaccine also must be given to travelers who are going to travel where the rabies is common, and they must be given at least 3 doses, that is 0, 7 and 21 days, 10 to 21 days, 3 doses for pre-exposure. And if it is a post-exposure, for example, if the patient is bitten by a rabid animal, then 4 doses needs to be given, and this must be spaced at 0, 3, 7 and 14 to 21 days. 4th dose must be given between 14 to 21 days. But if it is an elderly, then it is a 5 dose vaccination. We must be given 5 doses at 0, 3, 7, 14 and 21 3. So if it's elderly, 5 doses, otherwise 4 doses will suffice. And if it is a pre-exposure, then it is always a 3 dose must be people must be receiving the 3 doses of this rabies vaccination. Talking about this respiratory syncytial virus, it is a virus which causes the respiratory tract infection. It is not yet approved in India. In the recent past, it has been approved in other countries. There are this is a recombinant vaccine with or without adjuvant. It is given intramuscularly. The dose is 0.5 ml 1 dose, and contraindication must be taken into account if the patient has allergic history. Egg allergy or immunocompromised must not be given. So it is specifically indicated in the individuals who are above 60 years or older, and pregnant females who have this respiratory syncytial virus infection. They have very high morbidity and mortality rate, so they must receive vaccination at 32 weeks to 36 weeks, but they must be receiving this recombinant vaccine without adjuvant. They must not be given with adjuvant vaccine. Typhoid, if we talk about, this is actually a traveler's vaccine. If the patient is traveling to the endemic zone, so they must be vaccinated. We have inactivated typhoid vaccine, VI polysaccharide, typhoid conjugate vaccine, and we have live vaccine also. So all the other except this live typhoid are given by parenteral route. This live typhoid vaccine is given by oral route. These are the oral capsules, they must be given. And if available, if we have the availability, the typhoid conjugated vaccine should be preferred. So basically we have 2 types of vaccine which are very prevalent in India as VIPS and TCV vaccine. So again, if we have to choose between these vaccines, then typhoid conjugated vaccine must be given preference. Live typhoid vaccine, again, because it is a live, it is contraindicated in pregnant females. Though this typhoid, whom are the patient whom we should be vaccinating? The professional food handlers, specifically the persons who are running the mess in the hostels, in the colleges, in the areas where there is a mass cooking of the food. So these are the persons who must be given this typhoid vaccine. If the individual is unvaccinated and the age is 18 years to 45 years, they must be given TCV vaccine in the endemic areas. Again, I am telling in the endemic areas. Travelers, if they are traveling to the high risk of the exposure, they must be given this typhoid vaccine. In the outbreaks, if there is outbreak of typhoid, so usually it is recommended that they must receive this TCV vaccine. And in the pregnant, always weigh the risk benefit ratio, and if there is pandemic, obviously we have to supposed to. But again, here also we have to avoid the live attenuated vaccines. The oral vaccines, which are live vaccines, must be avoided. So these are the we talk about the Indian consensus recommendation. Travelers and mass gathering, specifically if the person is going for melas or Kumbh Mela or something like that, they must get this typhoid vaccine. Cholera, again, it is a disease of gastrointestinal tract. We have killed vaccine, and we also have live attenuated vaccine. Killed vaccine could be monovalent or bivalent, and these bivalent could be with cholera or without cholera toxins. So these are all for oral vaccines, and this is recommended for the travelers, for the mass gathering, for the potential cholera patient, and exposure to the persons who are exposed to the contaminated water and food, and where there is with this endemic or outbreaks, and during the natural calamity like floods and all, this vaccine is indicated. Chikungunya, again, this can cause this can be devastating in the adults sometimes, but it is not yet approved in India for clinical use. But in other countries, it is approved. It is a live attenuated vaccine. It should be given intramuscular route. One dose will suffice for the individual for 18 years or older with increased risk of exposure, specifically who are going to the endemic regions. They must be given this chikungunya vaccine. Contraindications are allergic reactions to any of the components of vaccine, and immunodeficient and suppressed state due to these medical therapy. If the patient is taking immunosuppressants, steroids and all, they must not be given, as it is a live attenuated vaccine. Now, yellow fever, if this is recommended, specifically if the patient is going abroad, specifically to this America and Africa, then these vaccine must be given, because some of the countries they need this vaccine card, that if before coming to that their country, these yellow fever vaccination must be taken. So these are live attenuated vaccine, must be given intramuscularly. One dose will suffice. The single dose of yellow fever vaccine provides long lasting immunity and must not be given in the allergic history, egg allergy, pregnancy, lactation and immunosuppression. But again, I am telling this not a routine recommendation. They must be given to a certain high risk countries, usually not recommended during pregnancy, but if this travel to that country is necessary, then risk benefit ratio must be taken into consideration, and decision must be taken accordingly. Single dose usually have a lifelong immunity, but booster dose may be required in some of the cases, like the patient who are vaccinated before the 9 months of the age, retropositive patient, the patient who are on immunosuppression therapy, and lab workers who are handling the wild type of yellow fever vaccine. They may need some additional doses too. Anthrax, again, it is not recommended for general use, but this is recommended for the pupils who are livestock handlers in the endemic regions, and laboratory workers who has high risk of exposure to anthrax. So this is basically a cell-free filters of microaerophilic cultures. These are avirulent, non-capsulated strain of Bacillus anthracis. It can be given intramuscular or subcutaneous route post-exposure or pre-exposure. If it is given pre-exposure, it is IM, and post-exposure, it is subcutaneous route. The dose is 0.5 ml and 0, 1 and 6 months. Booster dose, if risk-percent, it can be given 6 months after the primary dose, and if this risk is not there, we must not be giving. So it is not a general recommendation, but for the high risk of exposure, for the livestock handlers in the endemic regions and the lab workers, we must consider vaccinating with the anthrax too. So if it is a pre-exposure prophylaxis and the adult is a age of 18 to 65 years and they are at high risk of exposure, again there are 2-3 conditions. Pre-exposure, age is 18 to 65 and they have high risk exposure, then pre-exposure is intramuscular dose at 0, 1 and 6 months with the booster dose if the risk persists. Post-exposure prophylaxis must be given with antimicrobials. Antimicrobials must be initiated if there is risk of exposure, and this vaccine is given subcutaneously at 0, 2 and 4 weeks. So 0, 2 or 4 weeks subcutaneous in the post-exposure along with antimicrobials, and if it is a pre-exposure, then it is IM route and the dose becomes 0, 1 and 6 months. Then we have talked about number of individual vaccines. So there are number of vaccine, but how should we be using this vaccine? There are number of vaccines, then which are the patient? What are the point which must be considered before giving any vaccine to the adult? So there are 4-5 conditions. One is that we must determine the age of vaccination. What is the age? Because if we talk about this HPV, it is recommended for ideally within 26 years and not recommended after the 45 years of age. So age is important factors when we have to determine that which vaccine is to be given. We need to assess the conditions recommended for vaccine. For example, there are various medical conditions which are indication or which are contraindication for that particular vaccine, and we should always review the vaccine type, which type we are giving, whether we are giving inactivated, viral vector vaccine, we are giving a live attenuated vaccine specifically. So dose frequency must be taken into consideration, and interval again it becomes very important to mount the adequate immunogenicity must be considered, and special situation like pregnancy, immunosuppression, retropositive patient must be taken into account. Again, last but not the least, we must be reviewing about the contraindications before giving contraindication precautions before giving any vaccine type. So again, age, medical condition, vaccine type, dosing frequency, interval, any special situation, and any contraindication must be taken account before ordering any adult vaccine to an individual. So if we talk about Indian consensus recommendation, this is a very good chart we must paste on our OPD setups, that we clearly demonstrate which are the vaccines which must be given at which year. For example, if we talk about anthrax, it is not given routinely, but again, if there is risk, if the patient is going to the endemic zone, probably I would like to vaccinate, otherwise not recommended, usual not recommended. Chickenpox up to the age of 26 must be given. After that, if there is additional risk factors, then for example, if there is a history, the history of contact, then probably if the person is healthcare professional, then chickenpox vaccine must be given. Chikungunya, again, if the risk benefit ratio must be taken account, routinely not recommended. Cholera, if the patient is going to the high risk, if the patient is high risk for giving, for example, if there is a natural calamity, if the patient is going to the endemic, then again this cholera vaccine is indicated. COVID-19 is specifically indicated during an epidemic and pandemic. Hep and hepatitis vaccine, additional risk factor is present. For example, if you talk about hepatitis A, if the patient is suffering from chronic liver disease, if the patient is a transplant patient, so probably I would like to vaccinate my patient with hepatitis A. B, again, it must be given throughout the age. And this talking about HPV vaccine, again, as we discussed, that if the age is less than 26 years, probably I would like to vaccinate with HPV. Up to 45 years, it must be a sheer clinical decision whether to vaccinate or not, and is not recommended to use after this 45 years of the age. Influenza vaccine, very important vaccine, must be given. It is a seasonal vaccine, must be given can be given throughout the year and to each and every individual. Live attenuated vaccine must not be given. Live attenuated influenza vaccine must not be given beyond 40 years of age. Japanese encephalitis, talking about if there are additional risk factor, for example, if the patient is going to the endemic areas, then they must be vaccinated. MMR vaccine must be given up to 50 years. If this meningococcal vaccine must be given before 60 years. PCV vaccine specifically given after 50 years of age. Before, if the additional risk factors are present, like the patient is immunosuppressed, patient is having retropositive, then we should vaccinate PCV followed by 1 year, PCV 13 followed by after 1 year, we should be giving this PCV 23, and they are indicated above 50 years of age. All the individuals must be receiving this. So it is a geriatric vaccine which every geriatric patient must be benefited with this pneumococcal vaccine. Polio, it is indicated up to the 26 years. Rabies, again, there are two indications, pre-exposure and post-exposure. So if there is post-exposure, so up to the 60 to 65 years, 4 doses will suffice. After that, there are 5 doses to be given. RSV vaccine, syncytial respiratory syncytial virus, must be given if at all above 64 years. Before that, it is not indicated. Tdap, each and every individual must be vaccinated with Tdap, and followed by every 10 hourly 1 dose of TD or Tdap. So initial vaccine must be Tdap. After that, TD must be with TD or Tdap. Anything can be given every 10 hourly. Typhoid, talking about if there is at risk, then typhoid must be given, otherwise not. Shingles, herpes zoster virus, is specifically given after the 50 years. Again, it is also a vaccine for elderly, for geriatric population. Yellow fever, if there is history of travel to that endemic country, before going to that country, probably yellow fever vaccination is indicated in that individual. Now the CDC also have given a beautiful chart. Should take some additional account which are the high risk patients, which must be routinely recommended. So this is a chart, either we should follow CDC or Indian guidelines which is given by ABP can be followed while vaccinating the adults. Now age is one of the factors. Other, we should also take into consideration what are the high risk condition. Now if the patient is pregnancy, immunocompromised, HIV, asplenia, if end organ damage like CKD, heart and lung diseases, diabetes mellitus, healthcare professional, travelers, mass gathering, then there is again a beautiful chart that where we should be prioritizing our vaccination accordingly, that what are the recommendations in the specific clinical scenarios. So this is also very beautiful chart. Probably we must be we must be pasting in our OPDs that which are the vaccine which must be given in the specific clinical scenarios. Now, for these clinical scenarios, the consensus recommendations are it has to be prioritized which are the vital vaccine, which are the essential vaccine, and which are the desirable vaccine. Now, these vital recommendations, these encompass the vaccines which are critical for public health, right, targeting disease and with high morbidity and mortality, and we must emphasizing the universal coverage to achieve the herd immunity. Essential vaccine, these focus on controlling the disease with moderate to high burden, specifically prioritizing the target vaccination strategies to disease, usually to reduce the impact of the impact effectively. And desirable, there must be a cost this risk benefit analysis taking into account about the cost effectiveness, because the patient specifically who are these have some additional health benefit must be given this desirable vaccine. So depending on the priority, we have vital, essential, and desirable recommendations which are given to various populations. So if talking about healthcare professional, the Tdap, hepatitis B, MMR vaccine, and this chickenpox vaccine, these are vitals, must be given. Desirables will include influenza and this typhoid and pneumococcal. These are the essential vaccine. So depending on the priority that which we should consider that which are the vaccine which must be given, like Tdap, hepatitis B, MR, and chickenpox must be received by each and every healthcare individuals. So talking about this diabetes mellitus, again it which shows that this HPV vaccine, Tdap vaccine, hepatitis B vaccine, MMR, and chickenpox again becomes a vital. Other disease like influenza, the patient can also be vaccinated by influenza. This herpes zoster, this pneumococcal vaccine must be taken into account if the patient is suffering from any chronic conditions like diabetes. Then the patient who are suffering from heart-lung diseases, again they have a very bad impact on their health if they are not vaccinated. So they must be vaccinated specifically with influenza, HPV, Tdap, pneumococcal, COVID, MMR, chickenpox, shingles, and meningococcal must be considered depending on what are the recommendation rank of these individuals. Chronic liver disease, if it a patient of chronic liver disease, probably I would like to vaccinate with hepatitis B, one of the very important disease. If the patient is alcoholic, hepatitis B, HPV vaccine, MR vaccine, chickenpox, again these are the vital vaccine. Other which have to consider is influenza, again annually dose must be considered in these patients. This pneumococcal vaccine must be is comes under essential, and COVID-19 is also one dose is essential. Meningococcal is desirable in such type of patients. Pregnancy, 4 vaccines, these are must be given. One is influenza yearly, Tdap, each and every patient, each and every pregnant lady, every time the patient becomes pregnant, they must be given, preferably between 27 to 30 weeks, and it must be a Tdap vaccine in every pregnancy. It is vital. And again, COVID, if it is a pandemic or local epidemic, there is a COVID vaccine must be given. Hepatitis B is recommended, and influenza is also given on the yearly basis, even if the patient is pregnant. HIV, again these are the patient who have immunocompromised. HIV patient and other immunocompromised patient, they have decreased immunity because of retropositive, because of other the patient may be on various immunosuppressive drugs, various transplant patients. So these are the patient who are very prone to getting these vaccine preventable diseases, and we must vaccinate specifically to these part of this type of vaccination, because they can the patient can land up with various the mortality is very high if we don't vaccinate these patients. And specifically if in this category of the patients, immune status must be taken into consideration. For example, if you are giving a live vaccine, specifically if you are giving MMR vaccine, if I am giving, then probably if the CD4 count is more than 200, then it is indicated. If it is less than 200, it is contraindicated. But the same stands also for varicella also. And so in these type of patient, if we are giving live vaccine, they must be taken into consideration. And booster dose, specifically if you are giving this pneumococcal vaccine, then ideally what is recommended is this PCV 13 followed by PPSV 23 must be given. But here the booster dose may be recommended every 5 yearly in such type of patient, because they are immunosuppressed, because they are very high risk of getting this, because they cannot also boost immunity with 2 vaccines, with 2 doses. The probably third dose, booster dose, might be considered in such type of patients. Students who are traveling from India to international destination, so it is recommended to check individual countries immunization recommendations well in advance before travel, to check the latest recommendations. so that to avoid any problem while landing, and they might also contact the disease as such. Some common vaccine recommended. These are the few of the common recommended vaccine for international travelers. These are diphtheria, tetanus pertussis, hepatitis B, Haemophilus influenza type B, HPV, influenza, it is seasonal, MMR, varicella, meningococcal, this pneumococcal, polio, rotavirus, and tuberculosis, depending on which disease is prevalent and that particular area must be taken into account. So it is better to check the latest recommendation of that particular immunization, that particular country's immunization schedule, what are the recommendation, and we should follow and must take into account before going that. There are also recommendations for the persons who are traveling to India. It is recommended that they must routinely be vaccinated with MMR, Tdap, varicella, polio, COVID-19, pneumococcal, and influenza vaccine, depending on whichever is prevalent. These are the routine indications of this vaccine. Other vaccines like hepatitis A, specifically depending on the risk of the risk involved, they must be vaccinated with hepatitis A, typhoid, B if needed. That if one might have intimate contact with locals or required medical treatment during the stay, then they might receive this hepatitis B vaccination. Japanese encephalitis vaccine, again if there is travel to endemic region. Rabies, if there is risk of exposure to animals, the pre-exposure must be given at 3 doses, 0, 7 and 28 days. Cholera, if they are planning to visit to the outbreak prone areas. Polio, OPB is mandatory for people coming from the countries like Afghanistan, Ethiopia, Israel, Kenya, Nigeria, Pakistan, Somalia, at least 6 weeks before planned travel to India, and is valid for 1 year. The OPB vaccine is mandatory, specifically coming from these countries, for the mentioned countries. Meningococcal vaccine, talking about, 1 dose is recommended before 10 to 14 days of travel. Yellow fever is mandatory for travelers coming from Africa and South America, and also if it is the patient, if these individuals going from India to that particular country, it is also recommended to get themselves vaccinated for yellow fever too. Now there are various arts of the country who believe on religious functions. So there are recommendations that there are some mandatory vaccine for mass gathering within India, and these include that every patient must be receiving this typhoid, hepatitis C and influenza vaccine, and we can also consider giving hepatitis B, Japanese encephalitis and pneumococcal if their stay is prolonged. If the person is going outside India, for example Hajj, they must receive this, every patient must be receiving quadrivalent meningococcal vaccine, influenza, polio and pneumococcal vaccine if there is prolonged stay. So if mass gathering occurs in India, like Kumbh Mela and all, we must be giving this typhoid, hepatitis A, influenza vaccine, hepatitis B, Japanese and pneumococcal depending on the stay. And if they are giving outside India and where there is mass gathering, again we must be giving this meningococcal, influenza, polio and pneumococcal vaccine must be given before going outside India. Now, having studied about these vaccines, we have some upcoming vaccines also, like dengue, malaria, tuberculosis, HIV, leprosy and Zika virus, which are at the various stage. And the list is not this. There are many other vaccines also, which is in the various phase of the clinical trials. So hope we should get in the coming years that we must be able to give taking vaccines for dengue, malaria, tuberculosis once the recommendations come in the India too. So finally, I would like to conclude, adult vaccination plays a vital role in safeguarding individuals and public health. By ensuring high vaccination rates in the adults, we can effectively prevent and control the infectious diseases. We can protect the vulnerable population and reduce the burden of disease within community. Adult vaccination, it is beyond the individual protection by fostering the herd immunity and preventing transmission of the disease. So always and always, we the healthcare professional have a very crucial role in promoting this adult vaccination, and I will say that all of the healthcare professional, whatever is recommended, must be becoming the ideal by getting vaccination himself and then documenting it and promoting the vaccination, giving information to the other general population that how and when, what is the age, what is the high risk, then how they must be taking these vaccines. So this was all about vaccinations. Thank you. If there are any questions, I will be happy to answer that questions. And so these are my references that I have taken. Specifically, these are the Indian consensus, taken from Indian consensus guideline, which was released in 2024, CDC and WHO guidelines, which I have taken to prepare the slides. And important to thank that we are the small kids are thanking us for their vaccination. So why should not we take the thank with the this Ashirwad, what we call in Hindi, from elderly also, by vaccinating them with this vaccine preventable diseases. So thank you. So if there are questions, I will happy to answer.